Just quickly, and also must appreciate Osama for a very good presentation on the DBT. I would like to just briefly talk about developing and implementing early intervention psychosis in low and middle income country settings. That's including Pakistan. In the morning, just about an hour ago, I talked about early intervention psychosis. Kya hai? I will now present a brief overview of what we have been doing and what we plan to do in future. So, आज का एजेंडा मेरा प्रेजेंटेशन का ये है कि what is early intervention, why, how and where, who and when, किसने करनी है, कैसे करनी है और कौन इन्वॉल्व होना चाहिए. So what is early intervention in psychosis? I briefly touched upon it this morning. As I mentioned, early psychosis refers to early course of psychotic disorders, specifically period up to the 5 years, or early intervention psychosis services are generally care. There's a bit of difference. Some countries it's up to 2 years, some 3 years, but generally it's between 3 and 5 years. And why early intervention in psychosis? Because the early intervention psychosis services aim to do the maximum intervention in 3 phases of psychosis. The phase 1 is at risk mental state. Phase 2 is the acute and clear psychotic episode where you have well-established diagnosis of first episode psychosis, and the phase 3 is the recovery. I think I've talked about it, why we need early intervention psychosis. Simply because the first 2 to 5 years is the window of opportunity for you to make the maximum difference. I highlighted the reasons for that. So what actually early intervention psychosis services are? These are the typical EIP service. Early intervention psychosis service consists of a psychiatrist, psychologist, occupational therapist, a care coordinator who coordinates all the care, social worker, psychiatric nurses, employment support specialist, and a peer support worker. Of course, for a country like Pakistan, you cannot have all these professionals and this configuration of early intervention psychosis service. But I would try to highlight how it is possible to modify and implement these in our resource-constrained settings. First of all, why we need to do this in low and middle income countries? The demographic of low and middle income countries like Pakistan is such that in 9 out of 10 young people in the next 4 decades, 9 out of 10 young people are living in these countries. India, Pakistan, Sri Lanka, 9 out of 10 young people who are ultimately going to develop the psychosis in future, they live in these countries. So just because of the demographic structure of this population and the duration of untreated psychosis is twice as long in these countries compared to the high income countries. Take the typical example of Pakistan. 240 million population, median age of Pakistan is 23 years. And high prevalence of risk factors for early psychosis. So it's not only that it's younger age, it's also that we have other risk factors for psychosis, high prevalence of cannabis use, high birth rate, which leads to a high incidence of the purple psychosis, postnatal psychosis in the form of first episode, infections and their treatments. I have highlighted this. These are the four stages of the first episode psychosis, how it progresses. And as I've been mentioning earlier, that the first up to 25 years of age, you have the best opportunity to make a difference. So the question should be asked, have the early intervention psychosis services started in high income countries like UK about in early 90s, around 1995, and then they have been progressing well. Since then, there have been at least 4 systematic reviews and 3 meta-analyses which show that the early intervention psychosis services lead to significant improvement in some symptoms and functioning. They reduce hospitalization and they improve the outcome compared to the generic services, compared to the routine care as usual. Interestingly, there's a very good meta-analysis recently which showed that the cost effectiveness ratio is of early intervention psychosis compared to the treatment as usual is around $51,600 per quality adjusted life years. I don't have the time to explain the concept, but simply speaking, if you intervene early, if you provide effective services, you gain a lot of years of gainful employment, gainful education, and that offsets the cost of the providing the service. So the question I've been asking, can evidence for EIP be produced, mostly in high-income countries, be adopted for use in low and middle-income countries? Because almost all the evidence, we have just reviewed the evidence, and practically all the evidence for effectiveness and cost effectiveness comes from the high-income countries. Again, this is a typical example. So if you take one district, say for example, what you are looking for, what you are aiming for. If you take district Peshawar, where I work and my research is based, we expect to have around 2,600 cases of early psychosis across district Peshawar. So in a 2 million population, district Peshawar has about 2 million population, the number of cases in a year is around 2,600, and that means that, and what we simply ask is that this selected population is provided intensive treatment for at least over the next 3 years to prevent the psychosis. So it's not a big ask. First episode psychosis is, the incidence is low, the prevalence is high because the illness becomes chronic. We started a program of research around 1.5 years back, where we started thinking about adopting early intervention psychosis services. So this has the 4-pronged approach: identifying the community needs, identifying the relevant evidence, and adapting the guidelines. And then we are doing a pilot cluster RCT to pilot the study and then go for the full-scale early intervention in psychosis. So we did the ethnographic and qualitative studies. Ethnographic studies are where the researcher sits in the environment, becomes the part of the environment during working with the traditional healers. So our researchers sat and observed the traditional healers on average for about 5 hours per day, and see what they are doing. And we also conducted qualitative studies. I don't have so what we did we identified the community needs, what are the barriers, how the TSH, traditional healers, interact, because the reason we have involved the traditional healers is there's a good evidence from low and middle income countries that almost 90% of the people with first episodes spend about 2 years of their early course of illness with the traditional healers. So unless we work with them, what they do, how they perceive the illness, it's not possible to overcome the long duration of untreated psychosis. So these are the main qualitative findings. As I said, we're just publishing the paper. So along with the qualitative studies, we did the focus groups, we did the in-depth interviews, we did the ethnographic studies with the traditional healers, along with generating the evidence from our community. We also conducted a systematic review for identifying the relevant evidence in the low and middle income countries. लो एंड मिडिल इनकम कंट्रीज में किस तरह फर्स्ट एपिसोड साइकोसिस को मैनेज किया जाता है, क्या इंटरवेंशंस यूज़ होती हैं. We did a systematic review which is now being reviewed and is hopefully will soon be published. And we also made a group of young researchers who went through the guidelines and identified how these can be adapted. I talked about it briefly earlier in the morning. So the systematic review identified 18 studies from low and middle income countries, where that included 3 pharmacological intervention studies, 4 non-pharmacological intervention studies, 5 studies in which both interventions were used, and 6 describing early intervention psychosis in different phases. These are the main findings from the systematic review. We identified that there is some evidence for the use of non-pharmacological and pharmacological interventions and the service needs. So the next challenge is, you have identified the community needs, you have worked with all the stakeholders, including policymakers. You have identified the evidence from the existing literature. The next challenge is how you can integrate that evidence into guidelines, and that is what we are doing right now. We took the Australian clinical guidelines as a starting point because I feel that they are the most comprehensive guidelines, and in the group, we decided what are the guidelines, what are the recommendations in the guidelines which are not applicable to LMIC. Like I gave the example in the morning, like providing 12-session CBT, which in recommendation can be applied with no or minor modification, and which areas need completely new guidance. Like, for example, working with the families because of the different family dynamics over here. So based on this, which we have almost now finished. In fact, we have finished the first draft of the review guidelines, and I will be now I'm asking the PPS to distribute the draft guidelines for the expert review from psychiatrists, from our psychiatric community over here, psychologists, and all those the stakeholders. Once that is done, we will be taking those guidelines to external advisors in UK, Canada, and other countries to see what is the quality of evidence, and again have a very rigorous review. And we hope to have the first guidelines for early intervention psychosis for use in Pakistan and hopefully in low and middle income countries, I feel by March next year, because it's a very extensive process of reviewing the evidence, reviewing the guidelines, making them suitable. So that is what this is the process we are. One thing I must mention, that along all the process, we have involved the service users, people who have experienced the psychosis or their relatives in the whole process. They sit in our steering committee, they sit in our expert group, and they see the guidelines and comment on them, how much they are applicable or not. Along with this, we are just doing cluster randomized control trial of a pilot model of early intervention psychosis involving traditional healers. And again, this is a cluster which includes the enhanced, we are comparing the HOPE intervention, which involves the primary care traditional healers and the psychiatrist providing the care for the first episode psychosis following the guidelines. We are doing just the feasibility pilot study at the moment. And as you can see, we have recruited almost 50 patients so far. Because it's a early first episode psychosis is not that common. So we hope to have the results of the cluster feasibility RCT by end of May next year. So that evidence will inform all the work we are doing. Now my question to you is how we can identify and adopt the EIP roles, because we are identifying the guidelines, we are adopting the guidelines. My question to you is, what are the roles which can be provided in Pakistan? Psychiatrists are available, not those trained in the early intervention, but general adult psychiatrists are available in most places, at least in urban centers. Psychologists are available, occupational therapists, unfortunately, and social workers and psychiatric nurses, they are quite deficient. So we will need to work on them, how we can identify and train them for for working with the team. So just to summarize, we have been working on this for almost 2 years now. What we need to do is, I hope that we will have a working model. In fact, we do have a working model, but we are adopting, changing, improving it. We will have a working model by February, March next year. And then I would be asking you, especially those who are the policy makers, like the Dean of the College of Physicians and Surgeons, the President of PPS, those people, include early intervention psychosis in education and training, how it can be implemented, identify resources and adopt the early for guidelines in all centers, train psychologists, social workers, and most importantly, this is the next bit we are going to do. We are going to develop the quality standards. The quality standards for Pakistan, like say for example, the contact time, the use of the evidence-based antipsychotics. So we are going to develop the quality standards and then use those quality standards for early intervention psychosis services, which we aim to establish in Pakistan. My plan is that we should be starting with 4 or 5 centers, major centers, and then identify the needs and then improve the services using these quality standards, audit their, how much they meet the criteria for a good early intervention psychosis. And most importantly, I think ensure the free supply of medication for at least 2 years. This might sound you a very small step, but this is a very major problem. About 70% of people who would come to early psychosis services or any psychosis services, they cannot afford more than 1 or 2 months supply, and that is the biggest cause of the poor treatment adherence. And as I said, first, we cannot, schizophrenia is a chronic illness. Even if we cannot provide the treatment during the course of illness, at least PPS and the policy makers should ensure that at least first 2 to 5 years the free medication is supplied. So who and when? So I've given you an outline. It's you, me, and all. And when? Of course, we want to do it now. This is a huge work. I would like to acknowledge my research team, which included me, Mukhtarul Haq Azibi, Faraz, Abdul Jalil Khan, Nishani. These are the people who are working with me in UK. Patients and cares, traditional and spiritual healers who have been part of our study, Medical Research Council UK, which funded part of my study, and the NIHR UK, who fund my other studies. So this is what I have to say. All, thank you very much for listening to me. As I mentioned, I think I'll have to leave about 1, unfortunately. So if any question, I can take them now, if with the permission of the chair, or my contact should be available here. I'll be more than happy to answer any questions. Thank you.